Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today, we welcome Fatima Al-Shamari, as well as Miriam and Salsabel Al-Saidi. Fatima is an epidemiologist. Miriam and Salsabel are medical students, and together they co-wrote the Kevin MD article, Raising Reimbursements, the Medicaid Imperative. Everyone, welcome to the show.
Thank you, Dr. Ho.
All right. So I'm going to ask each of you just to briefly share your story and journey to where you are today. Fatima, why don't you go first?
Sure. So thank you so much, first of all, for having us. It's an honor to be here. So Miriam, Salsabel, and I all grew up in Washington State, and our lives were shaped incredibly by our refugee parents as they navigated the complexities of coming to a new country and facing language barriers. And they encountered a lot of cultural misunderstandings along the way that really permeated their healthcare experiences. And we were there as the oldest daughters in our families along the way, helping them navigate and realizing the critical need for compassionate, culturally competent care. So it took me a while, but I realized that, medicine is my calling and this is the direction that I want to head into. And I've been an epidemiologist for some time, just kind of doing research about, healthcare disparities and underserved populations. But really what I realized later on is I want to be on the front line with these two incredible colleagues of mine and just making that difference in person, just kind of being there, making it rather than waiting for, the policy changes to trickle down to the patient level. So that's kind of where my journey sort of circled to. I'll pass it to Miriam.
Yeah, Miriam, tell me your story and journey to where you are today.
Definitely well said, Fatima. So basically, from Seattle. I'm born and raised here, went to the University of Washington undergrad, then I went to medical school in Spokane, back here in Everett. And it's been a great journey because now I get to rotate here in Everett, Washington, where I used to volunteer here in high school. So I got to see different levels of volunteer as an undergrad student and now as a medical student, and probably even as a future doctor here. So it's very nice, actually, kind of this whole journey and where we're from. And so, both my sister here is with me in the journey here. So I'll have my sister go next year.
Go ahead.
Yeah, very similar story to both my sister and Fatima. They actually have a very similar story to my sister. We have almost essentially the same exact format, I guess. We went to university together, majored in the same, minored the same, entered the same medical school, had similar life experiences. And then I am also going to be rotating and doing my clerkship years in Everett as well, or at least in the Puget Sound region in Seattle. Yeah, very exciting stuff.
Perfect. So one of the things that Fatima mentioned was culturally competent care. So I just that means a lot of things to a lot of people, right? So Miriam, I'm going to ask you, when someone says culturally competent care, what does that mean to you?
Definitely. That's a good question. So culturally competent care basically is you try to understand the patient, where you're at and where they're from, without any assumptions, really. So basically, when you're talking with the patient, especially as a student, you're trying to make assumptions. You ask them kind of their story, get to know who they are in a short amount of time. So you can't really take the time to get to know the person from a short 10-minute visit. So what you can do is kind of ask them where they're at, kind of really briefly, what they're doing here and what their preferences are in healthcare and what they hope to get out of any visit. So this way you kind of understand the culture in a short amount of time. You can always read on your own. They tell you go read, go study, but nobody really has time to do that unless you're intentionally doing that. But with each patient you visit, you gain a little bit of a culture from every patient. So that's kind of how I understand culturally competent care, is try to understand each patient from their perspective rather than assuming what their cultures are.
And it's also about, during your training in medical school or even through undergrad, any exposure or any formal teaching when it comes to culturally competent care?
We do have a course in our medical school called Leadership in Healthcare, where we get to investigate how we present ourselves and our communications, especially from the patient perspectives and the power dynamics, and to better understand what that role we play in. And in particular, it's the being more empathetic towards patients. We need to understand them. Even in a short amount of time, you can pick up some clues. And then the more exposure you have, and we have different standardized patients, and then we have guest speakers come in, and just a wide variety of different perspectives.
All right. So let's talk about the Kevin MD article that all three of you wrote. It's about Medicaid, raising reimbursements, the Medicaid imperative. Fatima, tell us, how did this article come together?
Absolutely. So when Miriam Salsabil and I meet up, we love to discuss things related to science and healthcare. And so one of the things we realized is that our healthcare experiences, growing up converge where access to healthcare was a constant struggle. And we immediately understood the challenges that are faced by Medicaid patients because, they're just so ingrained. And we saw how difficult it was for our parents and others in the community. I myself have been a medical interpreter for my family and for others in community, and trying to translate those misconceptions about healthcare along the way and just understanding, where people are coming from and finding doctors who could communicate back effectively and appreciate these cultural nuances, as Miriam mentioned earlier, culturally competent care, and accepting Medicaid insurance as well, in addition to all these other factors. And witnessing that gap really ignited this sort of fire within us to kind of try and make a difference. And I had been following your podcast for some time. I couldn't think of a better place to send our article, but really we said, why don't we write something about this? And that's why we called it the Medicaid imperative, because really that's the direction that we should be going to. It's inevitable. We have to raise reimbursements in order to improve quality and access to care. And another way we wanted to make a difference was through raising awareness about, vaccines and medications for Medicaid patients and how to effectively use them. And I think this is a perfect segue. Miriam, if you want to elaborate and share the story about EpiPens and access.
Definitely. Actually, I have a really interesting story. Just last month, while we were celebrating the Eid holiday in our community with lots of food, and there's actually a girl that was suffering from anaphylactic reaction. And so I went to the scene, and she was surrounded with several bystanders, and she did not have any family with her other than an uncle who really didn't know what to do at the time. And I heard people say that she ate something with peanuts. Mm-hmm. And as I was absorbing the surrounding information and from a rapid assessment of her skin, airway, and breathing, I made the immediate decision that she needed an EpiPen injection now. And I asked if anyone had already injected an EpiPen, and they said no. And as I prepared to inject the EpiPen, I was actually met with resistance from the people surrounding the girl that we already gave her medicine, and they were physically stopping me from injecting an EpiPen. And I stood my ground and asked, was the medicine an EpiPen injection? And nope, it was an antihistamine. So that is when I decided to use my clinical expertise and knowledge and inject an EpiPen in this challenging situation where several people are dismissing your decision. And that is confidence and clinical expertise comes into play. And no matter what one situation is in, one should be confident in their clinical skills and education to be able to tackle any situation like that. And especially when minutes matter, like during the anaphylactic reaction. So ultimately, what I learned is that EpiPen hesitancy is real and something I've been working on promoting awareness of through like educational YouTube videos and working on a scholarly project, all three of us actually, on anaphylaxis awareness. And what is intriguing to me is that there shouldn't need to be a medical student to figure out that this girl was having an anaphylactic reaction, and anyone should be able to recognize anaphylaxis, and EpiPen should be the first line therapy. But with, like health literacy and people in the community understanding what's going on and people not carrying EpiPens, and you can't really find EpiPens anywhere because you have to have a prescription. You can't really get it over the counter, like AEDs, you can probably find that. But it's very interesting because I don't think you need a prescription to get an AED, but you need a prescription to get a life-saving medication that's an EpiPen. So I don't know if Salsabil want to add more to kind of like the whole EpiPen journey here.
Yeah, so an EpiPen without insurance costs roughly about $700. We think that EpiPen should be stocked right next to the AED or stop the bleed kits, as it is a life-saving tool, and schools, workplaces should have it on site because anyone at any time can get a life-threatening anaphylaxis reaction. And in 2017, there was a 400% spike on EpiPen costs. Medicaid reached an agreement that they will no longer be overcharged for EpiPens, so protecting access for Medicaid beneficiaries who rely on these life-saving drugs while Medicaid saves hundreds of millions of dollars. And how this relates to Miriam's story and raising Medicaid reimbursements is the government should raise the reimbursement rates to clinics. We've already come so far with the Medicaid. We've made great strides, including covering essential medications, for example, medications for diabetes. And when we have greater coverage for these medications, we're raising greater awareness amongst the less affluent communities about how these drugs and the necessities of these drugs. However, one thing that we can still work on is ensuring that these people know how to use these drugs appropriately, in particular, the EpiPen.
And Miriam, during that story that you were telling me, what was the reasons behind them trying to prevent you from giving that EpiPen? What were some of the reasons behind their hesitancy?
Definitely. No, that's a great question. So, well, I may appear young, but that's not really the big concern there. I think the main issue is that they're afraid there's a fear of needles. So the main two things for EpiPen hesitancy is fear of needles, fear of calling 911. So those two things, some people know actually, like if you inject the EpiPen, you have to call 911 because they have to monitor after injecting the EpiPen to see if there's any secondary reaction and to make sure that their anaphylaxis is being properly treated. But yeah, the main concern really is it's a needle. People are afraid of needles and they don't want to inject the needle. And they'd rather give pills by mouth instead of injecting a needle. But the issue here is one needs to understand the different mechanisms of what the difference between a by mouth medication is, which is an antihistamine, which is completely different from an injected EpiPen. And so there's issues there in terms of do people understand what an anaphylactic reaction is and what the main treatment for that is? And so there's a lot of confusion there. Some people think antihistamines because it's something you just drink liquid by mouth, and then you say, I'm good. And sometimes people will not get anaphylactic reaction. If they previously had a reaction that was just hives, not necessarily anaphylaxis, and they took antihistamine, they think that's all they need. But you never know when one gets an anaphylactic reaction. Just different amounts of the allergen could trigger anaphylactic reaction. So there's a lot of issues there. And so, but with community training and education, I believe that can be fixed.
Now, Fatima, when you were telling the story about the reasons behind why you wrote the article, you alluded to how difficult it was as you were growing up when you saw family members trying to access the healthcare system, right? So paint us a picture more about that. Tell us some of the difficulties that you saw in trying to access the healthcare system.
So one of the things that we grew up with is sort of accompanying our parents to their doctor's appointments, being the ones in the family that speak English and that are translating these sort of medical terms, or at least trying to when you're like 10 and 12 years old. It could be really challenging. But when you're on the other end, when you're sort of a part of the healthcare team and really listening to your parents' concerns about, why they don't want certain medications, or as Mariam mentioned earlier, why they don't want needles versus a pill. And that kind of touches on how they don't want the problem to escalate. Mm-hmm. So, they think that, a pill is sort of, keeping it under control, basically. But when you escalate to a needle, or when you escalate to actually going to the hospital and seeing the doctor, there are different levels. And a lot of people come from places where sicknesses are a taboo. And if you're ill, you don't want other people to know about it because that could be seen as a weakness. And so, kind of understanding these when you're going to the doctor with your parents, and this is, sort of the perspective that they've instilled in you, it doesn't really, conflict as much because you're saying, okay, this is what I grew up with. But when you're exposed to, the medical world, when you become a medical student, like my two colleagues, or when you're, working at an office or a clinic, and you really become exposed to these things and start saying, hey, this isn't right. This isn't, consistent with what we know about healthcare. Vaccines, COVID vaccines are perfectly safe and we can take them and they're not going to cause you to die. And so that's kind of really where it started out is this, cultural competency versus being on the other end and having to translate from Arabic to English, what our parents are saying, what our community members, families who request you as an interpreter, what they're saying about why they don't want this certain vaccine or why they don't want this certain medication. And sometimes doctors will say, well, okay, we can try something else. And I've also worked with doctors who say, well, why? What are your concerns about this? Why is it that you're afraid to take this injection, but not this pill? Mm-hmm. And so really coming to understand those, realizing that a lot of these misconceptions are really rooted in their experiences in their, countries of origin or from different generations, and these have been passed down to them, and really trying to address those, one patient at a time, because it's a generational thing. We are in this new generation where we grew up here, and we want them to realize, as parents and as aunties and uncles in the community, that really we're not just being too Americanized, and that we still understand the culture. We still have our roots and our thinking and our customs, that align with them, but sort of helping them realize that, this is where technology has progressed, this is how medicine has progressed, and really getting them sort of up to speed on that.
Your article is about the Medicaid reimbursement rate. So how does that tie into that lack of access when it comes to the Medicaid population accessing care?
It ties in because usually Medicaid patients don't get like the recommended treatment. They always have to do a step trial in order to finally reach that. So not only does it take a long time to finally reach it, because insurance would say, you haven't tried this for X amount of weeks or X amount of months, so we can't give you coverage or go to the next step until you do that trial and error process. And so that's taxing on the patient to constantly go back to the provider, take time out of their day, and just do this whole trial and error. Whereas patients that have commercial or private insurance, they can get it within a matter of weeks. So that's like the huge issue, is that there's always going to be a halt, and it's a long process in order to get to the recommended medication, even though providers know like this is what would work greatly for them and it has greater efficacy, safety. But it's just how the insurance is set up, is that they have to go through a whole trial and error process, and patients don't like that, especially since it's such a lengthy process and they're not feeling any better. If not, they feel worse. But it's just, there's no loopholes that we can
Sure.
like jump through or cut
what
corners.
would be a common condition where that step process would commonly come in play within the Medicaid population?
So what I've worked in the derm clinic, and I've seen this often when we're trying to get Medicaid patients on at least a biologic. So we have to try and fail topicals, try and fail oral pills, which are immunosuppressives, try and fail first generation Humira, first generation biologics. And we know the one, or at least a certain drug or biologic that works so well, but it's going to take them at least a year and a half before they finally get access to it. Some of them, they would have, some pharmaceuticals would have patient assistant programs, but some of them will get denied because they don't meet the criteria necessarily. So it's a bit tricky. And it's a very lengthy process.
Now, in terms of your take-home messages, I'm just going to ask each of you what needs to be done next. How can we solve this problem going forward? What ideas do you have? All right. So Miriam, why don't you go first?
Definitely. Yeah. So as both a future physician and patient, I've experienced kind of both how physicians prescribe certain treatment plans, but patients are not able to comply with it due to preventable cause, that is insurance coverage, time for prior auths, approvals, which delay treatment and lead to worsened outcomes. I experienced myself really as a medical student. It made me question kind of how I could improve the healthcare system as a future physician. But really it starts with like changing the healthcare system insurance, because once you fix that, patients are able to not feel stressed out. Physicians are not able to feel stressed out, because once physicians are burnt out, patients get burnt out, and the system just gets ruined. So it starts stepwise, fixing one problem at a time.
All right. And Salsabel, tell me about your solutions and next steps going forward, and some of your take-home messages.
The take-home message would be increasing awareness, especially for life-threatening conditions, and having not just an AED or a stop the bleed kits, but having other things that could help intervene and save a couple minutes.
All right. And Fatima, tell me about some of your solutions to the issues that you brought up, as well as some of the take-home messages that you want my audience to come away with.
Sure, Kevin. So I think my take-home message would be that doctors are doing the best they can to provide equitable access to care. I mean, during my pre-med journey, I was shadowing Dr. Daniel Lowe at a community clinic here in Washington, and really, he was the doctor that I wish I had growing up, observing him, seeing that, patients who would come late to their appointments, he would make a concerted effort to accommodate them. And even if it meant him going home later that day. And he showed me that equity isn't just a buzzword, and that doctors really are making an active and constant effort to work around these social determinants that dictate our ability as Medicaid patients to access care. But really, doctors can't do all of this alone. They need the government to support the doctors and to encourage more to start accepting Medicaid patients. And we firmly believe that fair reimbursement rates are essential to attracting and retaining these healthcare providers that are dedicated to serving Medicaid patients. So like Miriam and Salsabel said, I want to just reemphasize that we're advocating for policy changes, fostering collaboration between these stakeholders, and possibly leveraging technology to streamline the reimbursement processes so that we can break down these barriers in access to care.
Well, thank you all for sharing your stories, time, and insight. Thanks again for being on the show.
Thank
Thank
you
you.
so much. It was a pleasure.